Hello everyone, welcome to the presentation on supporting sexuality for people living with epidermolysis bullosa. This will be a review of the clinical practice guidelines published earlier this year. I'm Alex King, occupational therapist at Phoenix Children's Hospital and clinical lead for this project. We'll go over quickly today my background, the background of the project and the team, a little bit about the process, and then we'll spend the majority of our time on the recommendations the clinical practice guideline team has made and next steps and resources. Like I said, I'm Alex King. I'm our occupational therapy clinical specialist at Phoenix Children's Hospital in Arizona, the US. I work on our multidisciplinary epidermolysis bullosa team here, and I also volunteer on the board and as a camp counselor at the Camp Spirit Colorado Adventure Camp for RDEV, as you see here. I'm also a child life specialist and a recreation therapist, which means I have other training and specialty in educating and supporting families in with their medical conditions and in the hospital setting, as well as adaptive recreation. The project itself was supported largely by Deborah International in the greater CPG project curriculum, and the coordinator over there, Katya, is the primary support for these projects, and none of them could be done without her. Funding support for this project was from Deborah Norway, which was very generous and gave us everything we needed in order to get through the process, and submit for publication so that the article will be free for everybody to access. Our CPG team, as you see here, consisted of me as the clinical lead and Humphrey Hanley in New Zealand, who is our EB population lead. We were the first project to have a lead that lives with EB. We chose that because of the sensitivity and personal nature of the topic. We also have members of the EB community within our panel on the right, as well as psychologists, nurses, social work, myself, the occupational therapist, and dermatology. The method itself for creating a clinical practice guideline is shown on the screen here. We're not going to go into a lot of detail about this today, but I do want everyone to know the basics of the process. The topic is identified by Deborah International based on their own scoping surveys to figure out what's most important to the EB population as a whole. Then they work to identify who leads in the project may be, which are myself and Humphrey Hanley for this project. And then funding is identified, which, like I said, is from Deborah Norway for this. At that point, we identify a CPG team, which consists of people living with EB and clinicians from around the world, looking to represent a diverse population of people that serve and live with this condition. After that, the team itself conducts a needs assessment, which we completed through online surveys, which we'll talk about in the next slide. Once we go through those online surveys, we use those surveys to identify what the primary questions for the project are. Then we review the evidence in the medical literature, appraise it, which means we identify its strength and quality, and then pull out the information that's most appropriate and relevant to the questions we had identified. Once we have all that done, we submit for publication, and the publication provider, which for us is Orphanet, Journal of Rare Diseases, does their own process of evaluating the quality and strength of our article, has its own outside reviewers, and then once it passes that process, the project gets published. So for the needs assessment portion, I did want to mention how we did that. We didn't make any decisions prior to getting the results of these surveys. We sent 2 surveys out, one to clinicians that serve people with EB all around the world, the other one to people living with EB and their families. The surveys ask specific questions about, for clinicians, how they address sexuality for this population and their questions and barriers to addressing sexuality. In the EB population survey, our surveys primarily consisted of questions regarding history and experiences in sexual participation, desires, barriers, and facilitators of those experiences. So what helped and what was getting in the way of participating in sexuality the way people wanted to. We did publish limited aspects of these results that were limited in order to protect the privacy of people who responded. The CPG team received a generous amount of written responses to these surveys with testimonials that were very detailed, long, and personal. So those testimonials have not been published to protect people's privacy, but the CPG team did sit down and look at all the data and read every testimonial word for word together prior to making any recommendations or coming up with primary questions. So once we'd gone through the process of developing questions, we came down to two primary areas of need. Based on the survey results, there were two primary areas, which were psychosocial and mechanical barriers to sexual participation for people with EB. Psychosocial barriers consist of anything that relates to how a person relates to themselves or relates to other people, and how that might affect their ability to participate in sexual participation and build safe sexual partnerships. Mechanical barriers consist of primarily logistics and physical barriers to participation. These often had to do with positioning, pain, friction or shear, and other skin-related conditions, as well as internal or genitourinary conditions, so conditions that affect the structures that people use in sexual participation. So I wanted to start with our basic general consensus recommendations. These are things that the panel itself agreed upon as recommendations for anybody working with someone with EB. I'm not going to read these word for word, but I wanted to include them here so that you had a better idea of exactly what we stated. The primary recommendation here was that clinicians understand and evaluate how prepared they are and how appropriate it is for them, in particular, to address this need for people with EB. We recommended that clinicians evaluate their own biases and perceptions to make sure that their personal beliefs or opinions weren't affecting the person they're serving. We asked that they complete education and training specific to sexuality and health and sexual health so that they can best serve this topic itself. We asked that clinicians use an established framework from the medical literature for introducing these topics and supporting people to ensure that they're introduced and facilitated in a way that are respectful of all people's beliefs, preferences, and orientations. And then finally, we asked that clinicians make sure that they understand and adhere to their local, professional, governmental, and other restrictions, as the topic of sexuality does have legal ramifications and organizational procedures that dictate what parts of the topic can be addressed and how they should be addressed in different areas. So when we get to those psychosocial factors, so these are the factors affecting sexual participation that have to do with how a person relates to and understands their body and themselves as a person, and how a person relates to and understands other people. So we recommended that clinicians provide a holistic interview, which means that they interview the patient on their life, their routines, and their values and roles. And they should do this without judgment, meaning that the clinician's values, stigmas, and assumptions should stay outside the room, and the focus should be on the person that they're serving. We recommended that this evaluation be completed over time and repeatedly. So we wanted people to have access to this information at any point in their lifespan that it becomes relevant. For instance, if families have questions in the neonatal ICU or during infancy and early childhood about this topic and how it relates to their child's development, to puberty, to transition to adulthood, and how they picture their child's future, we want them to have the opportunity to ask those questions. We also want people along that pathway through their own development to have that opportunity, and no age should be an indicator as to whether this topic is relevant or not. We hope that clinicians will use specific tools to measure quality of life, to evaluate for symptoms and functional skills that might affect access to sexual participation, and to evaluate social skills and activity levels. So have a way to access information about a person's ability to interact with other people and their access to activities where they might meet those people. The team identified this as a primary concern because if people don't have the opportunity to participate in groups and activities in social settings, they have less of an opportunity to practice those skills, develop interpersonal skills, learn how to build relationships, and ultimately meet people that they might want to have a safe sexual partnership with. In regards to intervening for these factors, we recommended that clinicians provide age-appropriate education directly to the individual. This means that at whatever age, if these questions are apparent, the clinician is providing opportunities for patients to ask questions and access information that's appropriate to their age and developmental level in regards to this topic. Family education throughout development, as we discussed, should be available, and a lot of it should promote autonomy, self-determination, and self-advocacy. This means that we want clinicians to provide families support in teaching their children how to care for themselves, advocate for themselves, and understand themselves. We want clinicians to promote identity development, identify the places in people's lives where their appearance, their personal expression is impeded by their medical conditions or other factors, and identify ways for us to promote a person's ability to develop identity and self-perceptions, body image that works for them, and then express that in ways that work for their bodies. And finally, during the transition to adolescence, we strongly recommend that clinicians talk with families about providing opportunities for privacy, self-determination, and self-care skill development. We want people to have choices about how they access their care and how they care for their bodies, how they get through their daily routines. This is not to say that clinicians should determine how someone does those things, but clinicians should be available to help people identify how they'd like to get those things done in their day, in their daily routine, and to identify ways to reach that goal. As we move on to mechanical factors, just a reminder that these are factors that affect the physical ability of a person to access safe sexual interactions and safe sexual activities and access pleasure without pain. In the evaluation process, again, we strongly support a lifespan approach. We want people to both address this topic at every stage in the lifespan, but also to interview and discuss past, present, and future experiences that might affect a person's ability and perceptions about their access to sexuality. As always, we recommend a multidisciplinary team approach. We want early detection of and management of EB factors affecting genitals, the anus, or oral structures. That includes any other structures that a person might use or desire use for in sexual participation. Ongoing evaluation to encourage self-exploration, find ways for people to help them understand their bodies and explore their bodies, access pleasure. Consider all forms of sexual participation, so no judgment should be made by clinicians and no limitations should be placed on patients by their clinicians regarding what types of sexual participation are appropriate or necessary. Sexual participation is personal and based on personal values, and only those personal factors should be included in the evaluation. Individualized interviews should identify those personal values and preferences, and then previous sexual experiences should be reviewed to identify how those are affecting current function. Finally, it's really important to assess how much knowledge, use, and access people have to strategies to prevent sexually transmitted infections and diseases, and strategies for family planning and contraception. In regards to intervention, the goal is to address those things we evaluated. So we want ways to educate individuals on their body, their medical condition, and their sexual and pubertal development. By providing this knowledge, we provide them the opportunity for self-determination and decision-making that supports their values and their needs. We recommend that clinicians address masturbation as a normal means of sexual participation, as well as interpersonal sexual participation as both possible and natural for people with EB. Consideration of benefits for consequences of medical interventions on sexual participation is really important as well. By this we mean that we want providers to ask their patients and address with their patients how a medical intervention might affect their goals for sexual participation. This might include aspects of body image related to modifications or adjustment with medical intervention of how people receive their nutrition, of how people use their bodies. It could be hand function. It could be appearance of hands or mouth. All of these factors are things that people should consider in relationship to sexual participation. On that same front, body structures valued by the individual for sexual participation should be preserved and restored. We already do this when we talk about hand function, oral function, vision. We assess all of these because they affect the way we interact with our world. They affect the way we do the things that are most important to us. We ask that clinicians address body structures related to sexual participation in the same way. We ask that clinicians provide education and referrals to support adaptation and modification of sexual activities. This might be an occupational therapist or a sex therapist or another provider. By this we mean that if someone is having a hard time finding positions or ways to access sexual participation physically, that they be provided the opportunity to work on these tasks with a provider who has those skills. This might include shear reduction and friction reduction strategies like lubrication and commercial devices that support this need. It might include positioning devices and positioning strategies to improve endurance and decrease pain. And it might include some of those psychosocial factors as well. And finally, we ask that clinicians educate on sexually transmitted infections and sexually transmitted diseases, as well as family planning options within the values of their patient. These are strategies that have not been thoroughly evaluated by the research and need further data in order to make specific recommendations as to which STI and STD prevention strategies are safe and effective for people with EB, and contraceptive devices have not been validated or identified as ideal for the EB population. These are places of health equity that must be addressed in future research. On that topic, we have identified some places where we need more information in order to help people identify and access their sexual participation. I'm not going to go through all of these here. The most important aspects are that we need more specific information about subtypes of EB, cultural perspectives related to EB, sexually transmitted diseases, and contraception interventions for this population. We also need ways to evaluate and intervene, including quality of life measures that include sexuality, psychosocial factors, how to help people with self-image, body image, confidence. More information on timing, methodology, and decision-making related to genetic counseling and education. More information on how EB affects child and adolescent development and pubertal maturation. And then finally, specifics related to the mechanical factors, which means which commercial and medical products help for positioning, what are the best options for lubrication and friction reduction, how can we best maintain genitourinary structures in order to help support sexual participation, are there ways to reduce pain and fatigue, and are there human and mechanical stimulation methods or devices that are most appropriate for the EB population? While there's a lot of things we still need to know, the team felt very strongly that we had the evidence in the literature to support this primary statement. A diagnosis of EB does not inherently negate or inhibit an individual's desire or ability to participate in sexual activities, nor does it negate the human right to expression of an individual's sexuality. For more information on this topic, you can access the full clinical practice guidelines here. You can also go to the Deborah International website for full copies of the current CPGs and patient versions of those CPGs. You are also welcome to contact me directly at aking4@phoenixchildrens.com. I can't offer specific recommendations for personal questions, but I can offer support for clinicians in supporting people living with EB, and I can help to identify resources in order to provide more education on the topic. Finally, I wanted to review some acknowledgements. Deborah International and Katya are absolutely essential to this process, and it could not be done without them. Funding from Deborah Norway was fundamental to this process as well. I also wanted to acknowledge our review panel, of experts who reviewed our article prior to submission and gave us feedback to help make sure that it was as strong and appropriate and best served our population. Our survey respondents truly did drive the process and help us identify priorities in our process. Without the survey respondents and the generous examples and narratives that you wrote, we could not have completed this process in this level of efficacy. So thank you so much. And finally, our panel member, Julio Tanabe, and his mother, Yolanda, I wanted to recognize them. Julio was a fundamental piece of this project, and Yolanda supported him through that. Julio passed away not long after our final CPG meeting, and he was very, very happy and pleased to be part of this project, and we as well were happy to have him on it. Thank you so much for your attention today. Please reach out if you have any questions.